Sorry. So next speaker is Professor Takeo Goto from Osaka. So his topic is about the endoscopic keyhole skull-based approach for benign brain tumors. So Professor Goto, are you ready?
Thank you. Thank you, Professor Miki, for kind invitation. Today, I feel very honored to have opportunity to present my work in front of many friends in this webinar. At first, I will share my slide. Can you see my slide?
Actually,
My slide? Okay.
Yes.
perfectly,
Sorry.
perfectly.
Now, my topic is endoscopic keyhole skull-based approach for benign skull-based tumor. Recently, we know the endoscope can offer panoramic, wide, and clear view around deep city area. This feature is very useful for resection of the skull-based tumor. So today, I will present the pure endoscopic keyhole approach to some skull-based area. At once, I will show the anatomy of the endoscopic keyhole subfrontal approach. Usually, I put the incision around eyebrow and make the craniotomy with a size of about 3.5 centimeter, like this. And then we gently insert the endoscope around frontal base. We not retract the frontal base severely, but we can get the panoramic view around the paracella area. We can see both optic nerve, and also we can drill out the tuberculum sella and can open the bilateral optic canal without the severe retraction of the frontal lobe through the keyhole. So this approach can be applied to the medium size of the tuberculum sella meningioma. This patient shows a visual disturbance on the left side, and the tumor slightly has a dominancy on the left side. So the size of craniotomy is about 3 centimeters, and then insert the endoscope through the around the frontal base. Now we can observe the attachment of the tumor. Endoscope can offer panoramic view, so we can drill out the tuberculum sella and also can drill out the superior wall of optic canal at the initial stage of the surgery. Now I decompress the optic nerve. One of the benefits of this approach is that we can observe the medial side of optic nerve on the ipsilateral side. So uh, 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 people, but the surgical view is very similar of the interhemispheric approach. So we totally rejected out the old tumor like this. This is a post-op MRI. Tumor was nicely rejected out. This approach also can be available for the resection of the olfactory groove meningioma. So I use the same technique. I put the incision around the eyebrow and make the craniotomy with a size of 3 centimeters. And then we can get a clear view around the frontal base. So we dissect the tumor after internal decompression. Tumor was nicely dissected out through the keyhole. So pure endoscopic subfrontal approach was very useful for resection around the paracella or frontal base. I published this technique for World Neurosurgery last year. This is a second procedure, subfrontal keyhole anterior transpetrosal approach. This approach was useful around the medium size of tumor around the petrous apex. Usually, I put the skin incision around the frontal base and with the craniotomy with a size of 3 centimeters. And then we insert the around the middle position over the dramata. After cut the dramata medial side of GSPN, we can expose the causes triangle. After drilling out the causes triangle, we can open the Meckel cave. Finally, we can expose the trigeminal nerve from Meckel cave to brainstem. So we can also observe the SCA horse nerve. So this view is very similar of that of the microscopic anterior transpetrosal approach. So this approach can be applied to tumor around the petrous apex. This patient shows an uncontrollable trigeminal neuralgia after gamma knife. So I use a less invasive procedure to resect this tumor. I will show the surgical video. At first, I put the craniotomy with a size of 3 centimeters and then insert the endoscope to temporal base. I identify the GSPN and then expose the anterior petrous apex around the Kawase triangle. This is trigeminal impression. And then I drill out the petrous apex very carefully and then cut the SPS, most anterior side, just lateral to Meckel cave. Now, most part of the tumor was completely devascularized and detached. So we start the tumor removal. I finally cut the tentorium totally to expose the horse nerve medial side of tentorium. And then I dissect the tumor from the tentorium and resect the tumor totally. This case, tumor compress the SCA. So I mobilize the SCA of the trigeminal nerve like this. Then I carefully insert the endoscope more deep side. We can observe the 6th nerve and also confirm the 7th and 8th nerve like this. So this surgical view is very similar of that of microscopic anterior transpetrosal approach. This is a CT scan just after the surgery. Anterior petrous apex was limitly drilled out, and the tumor was nicely resected out like this. This approach also can be applied to the trigeminal schwannoma. This tumor occupies Meckel cave, posterior fossa, and infratemporal fossa. But endoscope can see. So I use the same technique and then carefully drill out the anterior petrous bone and expose the tumor. In case of the trigeminal schwannoma, just a subcapsular dissection was enough. We preserve the normal neural fiber and perform the subcapsular dissection. This is the tumor around the middle fossa. Also, this part was resected out. And then this is the posterior fossa. Now we confirm the tumor resected out through the keyhole. This is a relatively large trigeminal schwannoma, but the approach was totally same. Tumor was nicely resected out. This is a chondrosarcoma associated with osteogenesis imperfecta. For her vaginal invagination, the angle of the temporal edge was very steep, but to see the upper margin of the tumor, endoscope was very useful. So I use the same technique. Endoscope can offer clear and panoramic view. So, but angle was very steep, but we can observe the upper margin of the tumor. And then this is a trigeminal nerve. We dissect the tumor from the medial side of the trigeminal nerve. This is the trigeminal nerve, and this is a tumor, and this is a brainstem. So through the keyhole, we dissect the tumor piece by piece, and finally all tumor was resected out. This is a post-op MRI. Tumor was nicely resected out without any deterioration of symptom. This is another case of the medium size of petroclival meningioma, but the patient age was very old. So I choose a less invasive procedure to resect this tumor. Surgical procedure same. I put the keyhole craniotomy and put the endoscope around the middle fossa. I stimulated the GSPN and cut the medial side of GSPN to expose the petrous apex. And this is a trigeminal nerve. After expose open the Meckel cave, I drill out the petrous apex. This is the trigeminal nerve. I completely drill out the petrous apex to go to the posterior fossa. Now I cut the SPS and also cut the tentorium. This is a tentorial edge. I cut the tentorial edge to confirm the fourth nerve and SCA. This is the attachment of the tumor, medial side of the trigeminal nerve. We can identify the attachment of the tumor with high magnification. So I effectively decompress the attachment of the tumor. This is a trigeminal nerve. So the attachment, medial side of trigeminal nerve was completely detached and removed. So I resect the tumor piece by piece, like this. Inferior part of the third nerve. So surgical view is very similar of the anterior transpetrosal approach. So most part of the tumor was nicely resected out through the endoscope. This approach also applied to petrous apex meningioma nicely. And also this tumor has a wide attachment from the sphenoid-rich cavernous sinus and posterior fossa, but the tumor was small. In such situation, also endoscopic keyhole and like this, and then we remove the tumor piece by piece. This is a trigeminal nerve. We open the Meckel cave completely and resect the tumor around the posterior fossa. And this is a lateral wall of cavernous sinus. We can see the lateral wall of cavernous sinus from the through the endoscopic view, and resect the tumor piece by piece. And finally, all tumor was resected out through the keyhole. So this pure endoscopic anterior transpetrosal approach was also very useful procedure. So recently, I published this technique, include a video clip. So if you have the interest to this technique, please check this paper. And finally, I present the endoscopic keyhole interhemispheric approach. This is the Falx meningioma, but located around middle third. In such situation, endoscopic keyhole contralateral approach very useful. I place a patient to lateral position and then insert the endoscope posterior interhemispheric fissure. I detach the tumor effectively and remove the tumor like this. Endoscope can offer the clear view around the deep-seated area, so it's useful to carefully dissect the tumor. And finally, all tumor was resected out like this. This interhemispheric keyhole approach can be applied to the tumor dorsal side of midbrain. This is a midbrain cavernous angioma. I use also same technique. This is the storage sinus, and this is a tentorium. I place a patient to lateral position and then cut the tentorium. So it's like the OTA. This is a deep venous system, and this is a cerebrum. I directly reach the dorsal side of the midbrain. So this is a cavernoma. I carefully dissect the tumor from the dorsal side of midbrain. And finally, all cavernoma was resected out. If I use a microscope, surgical view is like this. So it's very difficult and seem very dark to follow the margin through the keyhole. But the endoscope was very useful to resect the tumor through the keyhole. This approach also can be applied to olfactory meningioma. I place a patient to lateral position. Patient shows a hydrocephalus, so I put the ventricular drainage and start the tumor removal. This is attachment of the pulse, and this is a tentorium. Under the endoscope, we can find out the clear view, and we can preserve the deep venous system. So tumor was nicely resected out with preservation of the deep venous system. If the size is large, but we can apply the same procedure, and we place the patient lateral position and insert the ventricular drainage, and then we insert the endoscope. We can observe the clear border between the brain tissue and tumor, so we can precise detection of the tumor. And finally, all tumor was nicely resected out and also preserve the venous system. So pure endoscopic keyhole interhemispheric approach was also very useful technique. I also published this technique to World Neurosurgery. Today, I present the three keyhole endoscopic approach: subfrontal route, subtemporal route, and interhemispheric route. In each procedure, the proximal side of the endoscope is very safe area. So we can apply this to deep-seated area. So of course, there is some technical tips, but the proximal side of endoscope is very safe area. So these three approaches can be very effective procedure for removing the various kind of skull-based tumor. Thank you for attention.
Thank you, Professor Goto. So, very elegant presentation with beautiful. There is one question on the chat. Okay. Thank you very much for this beautiful presentation. And Dr. Goto, can you read the questions?
Yeah, chat. Okay. So I
Yeah.
will answer the chat.
Yeah.
Okay.
Yes, the question is about do you prepare for spinal drainage? Do you use a spinal drainage before surgery
Yes.
to drain the CSF?
Mm.
Do you
In
routinely
key,
use the drainage?
yes. In keyhole surgery, I usually prepare the spinal drainage to relieve the tension. But subfrontal approach, usually no need to evacuate the CSF during the surgery. But I prepare the spinal drain in all cases.
Okay, for all cases. Okay, thank you. So any other questions? Dr. Goto, so thank you for your presentation from the very straightforward case to the very complex case. My question is about for example, the frontal skull base approach, very simple case. Do you recommend the young neurosurgeon to apply this procedure from the beginning? Do you think it's possible if they perfectly follow the indication? Or do you think they have to train in the ordinary microsurgery and then move on to the keyhole surgery? What is your
Uh,
idea from the view point of
quick approach. So I always advise our young staff that was it's better to understand and master the microscopic skull base or frontal or skull base approach. And basically be performed in the microscopic surgery. It's my idea. Thank you. Comment.
Okay, thank you. I understand very much.